My name is Nigel Henderson. I'm one of the trustees of Stoke Mandeville Spinal Research, and I'd like to extend a very warm welcome to everybody who's given up time to attend this morning, this webinar that we have to launch our next two research projects. Many of you, of course, will know and be familiar with Stoke Mandeville Spinal Research. But for those who do not, I'll just summarize that we are an independent charity based at the National Spinal Injury Centre, and our mission is to fund quality of life research on behalf of spinal cord injured people. And we hope that these exciting, in fact, we're sure that these exciting new projects will make a real difference to people's lives. Now, we've got a lot, I hope, to discuss this morning. So if we just review the agenda for the morning. Slide, Derek. I've been doing the introduction. First to speak will be Kat Panagaki, who's one of our ambassadors and a spinal cord injury advocate. She will share her personal perspective on why research into neuropathic pain, one of our two projects, and mental health, the second one, matters so deeply to those living with spinal cord injury. Next up will be Dr. Jan Rosner from the SCI Centre, Spinal Cord Injury Centre of Western Denmark, who will introduce his project exploring whether the medication bupropion can provide effective relief for severe neuropathic pain after spinal cord injury. This is a condition that current treatments often fail to address and is a hidden condition that so many spinal cord injured people suffer from. Next up will be a joint presentation by Dr. Mohit Arora of the University of Sydney and Dr. Jane Duff, who works at the National Spinal Injuries Centre, and they will present their mental health and well-being project, which focuses on embedding practical, evidence-based strategies to support emotional resilience and well-being for people with spinal cord injury to their rehabilitation journeys. We'll then have a combined Q&A and take questions. You can put questions into the chat at any time, and they will be picked up. Put them in when they occur to you. And then we'll finish off with a few words from Raquel Siganporia, who from Aspire Law, who are very kindly sponsoring this webinar this morning. So we're very grateful to them. So I think without much more ado, we'll move to Kat, who will give us a few words about her perspectives.
Hi everyone, and I find it really exciting that you've all joined, and it's something that I really believe in because I'm Kat. I'm 33 years old, and 12 years ago this month actually, I got into a taxi in Athens from the airport, and the taxi driver kept turning and talking to me and he crashed into a tree, which that resulted in me breaking my neck, which I'm a C4, C5 incomplete spinal cord injury, which that means I have no, I'm paralyzed from the shoulders down, but I've got quite a lot of sensation, which unfortunately that results to a lot of pain because the signals that pass as like anyone would, let's say, feel touch on their arms. For me, it's like it comes through neuropathic pain, and that's why, for me, especially talking about these two research in neuropathic pain and mental health is such a huge part of spinal injury that at the beginning when I first had the injury, I thought the most important part was walking or, move. But I realized very soon that it's actually one of the last things that most people will ever that got a spinal injury will actually think of wanting to be the first thing they want to, find a solution or find or change. And um it's something that I never at the beginning I never actually, when I heard people say that spinal cord injury, that the walking is not something that they think about anymore, and it's other things that like neuropathic pain, mental health, function of, of upper limb and many other things. I used to think, oh, they're just saying it to make me feel better, but it's actually something that affects more your life than I ever even thought or ever could imagine. Um, at the first year of my injury, I didn't feel neuropathic pain. I wasn't. I didn't really know what it was because it's something that you can't really explain easily for somebody that doesn't hasn't felt like I hadn't felt it before. And then from the second year of my injury, when I became an incomplete injury, and that's when it started. And it's a pain that's a 24-hour pain. It doesn't go. And it's a constant, it's like a very intense pins and needles, but with like fire. So I feel it from my lower back until my feet, and sometimes on my hands, which if the only time they does kind of get resolved, like I don't feel it, is when I sleep. But there is times when if I do hurt a lot, then I see it through my dreams. So the pain wakes me up through my dreams. And that's the reason why, my neuropathic pain has affected not only during the day, but at night. Most of the time, I can't sleep due to the pain. And it's something that I haven't found all the years I've been injured. Up to now, there's no tablet, there's nothing that has ever taken that pain away, even like the slightest. It gets a little bit better, but it's always there, and it's something that it's difficult to. You have to find a lot of mental strength in order to go through the day, because you have to. There's no choice. You either stay and do nothing all day, and that's. I was injured when I was 21, so that for me wasn't an option to not do anything. But I can't remember what it felt like to not be in pain because it's been so many years, and knowing that there's something is close to happening that could actually take, even if it took like 20% off or 10%, for me that would change my whole life. It would, because I actually can't remember what it feels like to be in less pain. And it's knowing that, there's been research. For me, neuropathic pain would be one of the first things that I would want something to change. And that's why I feel so strongly about these, well, I feel strong about all of the research, but especially the neuropathic pain. For me, it's something that I know it's so many people, suffer from, and it's difficult to live every day with it. And sometimes you're like, I want to just give up, and it's, but then, and that's where the mental health comes through, because it's, the beginning with it. Like, that's the second research that I think it's so important, and we kind of all forget about it because it's still a bit of a stigma to talk about, you know, how we feel, and not only as a patient with spinal cord injury, but even the families, the, partners, parents, everything. But when you first get injured, it's like your mental health is, it's kind of like, I call it confused, because you're not sure what's happened. You think that it's all going to get okay, and it's just going to get a bit of physio and that's it. You're going to get back to normal. And I remember when it first hit me, that I heard somebody, one of the porters said, we've got a tetraplegic coming through for a scan. I'm like, wow. And that's when everything kind of like psychologically shatters, and it will trigger something. It was just the word, I've got tetraplegic, and that's when it hit. And from that moment, it's you try and go through because you want to be strong for everyone else and from your family, but inside it's like it's something that I can't even explain. And I mean, and I found it very difficult to actually feel better until I actually went to Stoke Mandeville, and I was surrounded by people that do have spinal cord injury, and people that doctors and nurses, any profession that could understand or was working around. Then I thought, okay, there is a community that I can rely on. And after Stoke Mandeville, that's when I started feeling better psychologically. And one of the hardest was coming out of hospital, getting discharged, because I was in hospital for 2 years. And knowing that even for that, there's something that people are researching, and it's so much more important than we we all want to believe, if you want to say, because it's something that I even struggle. Like every day I struggle to like say, openly how I feel, or like sometimes being so, like I said, so paralyzed from the shoulders down, you lose all your independence. And I was somebody that was very quite independent, maybe too much when I was a teenager. And it was sometimes you feel like I'm lazy or something, and all that does affect you constantly in your head. But that's why I've when I met Charlotte first at Stoke, and she spoke about it. I was like, yes, that's definitely something that needs to be more known and more, because I would want to know, and I didn't know anything before my injury. So
Okay.
that's my little, like, the 1%.
Thank you very much indeed,
Well,
Kat. That's really good. That brings it all to life, and it tells us all why we're here and have an interest, and research and work in this field is really important. So next up is Jan Rosner. Has a background in clinical neurology and neurophysiology. He earned his medical degree from the University of Heidelberg and completed further training in Switzerland. He currently holds a dual appointment as consultant neurologist at the Spinal Cord Injury Centre of Western Denmark and associate professor in translational neuropathic pain research at the Danish Pain Research Centre at Aarhus University. And his research focuses therefore on neuropathic pain, particularly following spinal cord injury, as well as other interests in neurological assessment, neurophysiological assessment and pathways. So it's our great pleasure to welcome him, and our great pleasure as a charity to be helping to fund this research into such an important area, as Kat made plain and pointed out. So, Jan, welcome.
Yes, thank you very much for the kind introduction. I hope you can see my slides. Yes?
Yeah.
Okay.
Yeah.
Good. I hope my connection is good. I'm not on the camera right now, but I will come on the camera later for the discussion, so I have an optimal connection for my presentation. So thanks a lot for the introduction. It was very impressive also to hear the account of you, Kat, about how pain affects every aspects of life. And I've been interested in neuropathic pain after spinal cord injury, maybe over the last 10 years, done lots of experimental work on it, clinical characterization, and I'm very happy that I now get the chance due to the... Sorry? Is my connection okay?
Yes.
Yeah.
Okay, sorry.
Yeah.
I
We
thought
can
someone
hear
had
you.
a
I
question.
think somebody wasn't on mute, I think.
So I'm very happy that I now got the chance, due to the generous funding from the Stoke Mandeville Spinal Research Foundation, to move into the next stage to conduct a trial with bupropion for neuropathic pain after spinal cord injury, something that we call the BUNEP trial. Bupropion is a drug which is already approved, not for pain though, but for smoking cessation. So if you use it now for pain, it would be an off-label use. But there's some very interesting data, both from animal models or some other musculoskeletal pain conditions, that it might actually also have an impact on pain. And recently in Denmark, there was also a study conducted in peripheral neuropathic pain after diabetes, where bupropion also showed some very good effect. And this motivated us to look more into the effects of bupropion on central neuropathic pain, central nerve pain after spinal cord injury. The good thing is, if a drug is already approved and just needs a new indication, there's a potentially also pathway to get this to patients with spinal cord injury if this drug has a positive effect on neuropathic pain. So nerve pain after spinal cord injury is very frequent. It can be below the level of injury, it can be at the level of injury, it can have very different characteristics. There's data indicating that up to 60% of individuals who sustained a spinal cord injury suffer from nerve pain. And we heard before that this affects all aspects of life. There are, of course, other types of pain that can also occur after a spinal cord injury. Musculoskeletal pain is a big group. Among musculoskeletal pain conditions are overuse pain or spasticity pain. There's also visceral pain, so pain from the inner organs. And these may overlap with neuropathic pain conditions. But our research here and our trial focuses on neuropathic pain after spinal cord injury. And we have some data to support maybe also the most debilitating pain conditions that occurs after spinal cord injury, and also most difficult to treat. As I mentioned, I've so far focused a lot on the mechanisms of neuropathic pain, and this is a study we could recently publish investigating the mechanisms. So if you have a spinal cord injury, as shown here on the left-hand side, there's many things happening at the level of the spinal cord. You are severing the so-called descending inhibition that comes down from the brainstem or brain to the activity of nerve cells at the spinal level. So at the end of the day, what occurs at the spinal level is a state of hyperexcitability. This, we believe, is the case in any kind of spinal cord injury. So there's always some kind of hyperexcitability. In pain patients, as shown here on the left side, so we investigated this in two groups of patients, one suffering from neuropathic pain here on the left-hand side, and one without neuropathic pain here on the right-hand side. We have seen that in both cohorts, those with and those without pain, there's some kind of indication that there's hyperexcitability at the level of the spinal cord. But only in the group here on the left-hand side, where there's also a preservation of the pain pathways, so something that kind of conveys that hyperexcitability up to the brain, no pain. Only in this group here, the patients are actually suffering from pain. So you need that hyperexcitability, but you also need some kind of pathway preservation, this hyperexcitability to reach the brain in order to feel pain. What we are trying to do with all kinds of medication that we are using at the moment is to dampen this kind of hyperexcitability here. And of course, this also comes at the cost of certain side effects, because you cannot specifically dampen hyperexcitability in the spinal cord. You always also dampen it at the brain level. So there is side effects like nausea, drowsiness, vertigo, all these kinds of things. Often dose limiting with the drugs we currently have. So there's really an unmet medical need, an unmet need for better pain treatment. So these are actually the first line medications we are using at the moment: pregabalin, gabapentin, antidepressants, for example, tricyclic or serotonin reuptake inhibitors. And if you look at the so-called NNT, the number needed to treat, so how many people do you actually have to treat with that drug in order to get a pain relief? If this ranges between 6 and 10. So you need to treat many people actually statistically to get a significant effect. So really an unmet need for better drugs. I've shown you this here. It's a very busy slide. I don't want to go into too many details, but drugs act at different sites in the nervous system. We have certain drugs that act at the peripheral nerve terminals, along the peripheral nerve fiber, or here on the right-hand side in the picture, on the central aspects of occurs in the spinal cord. And here in yellow in the upper right corner is something very important, the aforementioned descending inhibition. So there's something coming down from the brainstem or from the cortex that dampens the processing of noxious, of potentially painful information at the level of the spinal cord. And this descending inhibition, which acts kind of as a brake in pain transmission, uses different transmitter systems, which we can, for example, antidepressants, which then increase the level of these transmitters. And the idea is that in doing so, we kind of increase the strength of this descending inhibition. And this is actually where we believe bupropion will also act upon. And there's evidence from experimental studies that this is the case, because bupropion is actually a norepinephrine dopamine reuptake inhibitor, which acts at this site here, at the site of descending inhibition. So if we increase this with bupropion, maybe we can reinstate that brake that dampens pain transmission at the level of the spinal cord and also reduces the aforementioned hyperexcitability that comes after a spinal cord injury. That's the idea. Can we measure that descending inhibition? And that's also a part of our trial. So we will use bupropion to study the effect on clinical pain, but we also want to investigate predictive markers. Is there anything we can test to see, okay, will this individual potentially benefit from the use of bupropion? So we can actually measure the strength of this descending inhibition. That's what we do with the so-called conditioned pain modulation paradigm, or a pain inhibits pain paradigm. So if I apply a painful stimulus here, a heat pain stimulus, this is perceived at a certain threshold called the heat pain threshold. It's physiological. If I now put my other hand here into cold water, 9 degrees, for 2 minutes, this is also quite painful. This elicits a strong painful sensation over 2 minutes. If I then take my hand out of the water and apply the very same heat pain threshold, then the threshold goes up. So the same stimulus is perceived less intense. So we have here a way of investigating this top-down pain inhibition. And if in our patients this conditioned pain modulation is intact, so if we can really see this effect here that I've shown you in this figure, then they might potentially benefit more from the use of bupropion, because bupropion can then engage with that descending pain modulatory system. So our study design is, our aim is, we would like to determine whether bupropion reduces neuropathic pain in individuals with chronic spinal cord compared to placebo. So it's a placebo-controlled trial, the highest level of evidence one can generate. We also would like to assess secondary effects on mood, sleep quality, fatigue, functional activities, overall quality of life. And as I've mentioned, evaluate this conditioned pain modulation paradigm as a predictor of treatment response. Our hypotheses are that bupropion will significantly reduce neuropathic pain intensity compared to, and that treatment efficacy is associated with preserved pain modulatory capacity, which is indexed by what I've shown you before, a high CPM, a high conditioned pain modulation efficiency. So a strong pain inhibits pain effect. Our study design is, it's a randomized, double-blind, placebo-controlled crossover trial. So we anticipate to recruit 35 adults with chronic spinal at least more than 6 months after injury and SCI-related neuropathic pain. There will be a 6 weeks treatment with either bupropion or placebo, then a 2-week washout, and then another 6-week crossover treatment. So those individuals who first receive bupropion will then receive placebo and vice versa. So it's a crossover trial. Where do we stand in the project? Of course, a clinical trial is lots of administrative work, which we are currently in the process of getting the upper hand on, so to say. We also, and this was not trivial, we managed to get a placebo production in place because we have to talk to certain pharmacies because the drug is available, but the placebo has to be produced. And sometimes if pharmacies produce placebos, they will just coat the drug in some sort of coating, which makes the pill very large and very difficult to swallow. So we were in contact with different pharmacies in Denmark and found one that can actually produce it in a way that is actually followed by our participants. For this, we have actually co-funding from the Lundbeck Foundation by Professor Nanna Finnerup from the Danish Pain Research Center. We could recruit, and this is also very important for this project, a PhD student. He will start mid-March. We have some kind of patient database from previous studies and ongoing recruitment. So we have right now, because recruitment is also a bottleneck in these studies, we have right now 20 patients that are eligible. So we need 35 in total. So it's quite good, I think, that we already have 20 which are eligible for this kind of study. And this is the stuff that takes most of the time at the moment, all the regulatory documentation, the ethical approvals. That is what we are currently working on. And we hope to be able to recruit or to include the first patient, after summer this year. So again, thank you very much for the Stoke Mandeville Spinal Research Foundation for giving our team the opportunity to kind of go the next step to conduct a clinical trial in the field of spinal cord injury and neuropathic pain. And thank you very much for your attention. I'm looking forward to the questions later on.
Thank you very much indeed, Jan, for a very clear and interesting presentation. I'm sure there'll be many questions to field later on after the next presentation.
Thank you.
By Mohit and Jane. Mohit is a senior research fellow at the John Walsh Centre for Rehabilitation Research at the University of Sydney. And he focuses on spinal cord injury rehabilitation and mental health, specializing in integrating the psychological support and emotional resilience into physical rehabilitation. And he's working with Jane Duff, who is a consultant to clinical psychologist and head of the psychology team here at the National Spinal Injuries Centre, with over 30 years experience in this field. And she combines both her clinical practice with research, teaching and consultancy, focusing on the psychosocial outcomes and long-term well-being. So we're looking forward to this talk, and I won't take any more of your time and let you begin.
Thank you, Nigel, for the introduction. Can you hear me okay?
Yes, we can.
Perfect. Thank you. So good afternoon, everyone. On behalf of all investigators listed on the slide, welcome to this session. And today we will be presenting and very excited about this new project, which we got from the Stoke Mandeville Spinal Research funding about co-designing, implementing and evaluating strategies with peer support professionals to enhance the mental health and well-being for people with spinal cord injury. So just for your easy navigation of the slide, what we have done is Jane will start by explaining the current landscape of rehabilitation and psychological support in the UK and Australia, following which I will provide some insights from our partner charity organization, and then the tools that we will be using to deliver the project outcomes and why this project really matters. So before I hand over the mic to Jane, I would just like to mention that I'm based in Sydney, Australia, and I would like to start by acknowledging the traditional owner of the land on which I live and work, and pay my respect to past and present and emerging elders. And now, thank you for listening, and I'll hand over to Jane.
Thank you very much, Mohit. Good afternoon, everybody. So in the UK, the locations of spinal cord injury centres are based on historical need and not the current population demand. And there's bed capacity pressures, particularly acute in southern England. In the absence of a national registry, it used to be thought that about a third of people did not access specialist spinal inpatient rehabilitation, and a third were treated through the outpatient path. However, recent research has identified the gap, unfortunately, to be much larger, with only 20% being admitted to spinal injury centres. Australia, which is similar to England, thank you, Mohit, has 8 spinal cord injury centres. Australia does have a national registry, but this does not function as a comprehensive lifetime clinical registry currently, and information is drawn from longitudinal research data. Like England, Australia also has a gap in people being admitted to spinal injury centres, but less so at around 40%. So in February 2020, NHS England remodelled spinal cord injury services in England, broadening the scope to so that centres were responsible for all patients in their catchment area, which led to a greater number of people with spinal cord injury being identified, and an estimate that someone sustains a spinal cord injury every 2 hours rather than previously thought of every 7 hours. But there's 2 issues still related to that. It's still likely to be an underestimate because there's not a mandated register like I mentioned, and also the number of commissioned spinal cord injury beds hasn't changed. Thank you, Mohit. Next slide. So as part of this review, there were several transformation projects to set new standards, and I led on the psychological and mental health group. The report was published in 2023 and suggested several changes. The most fundamental was to move from a referral-based model, which is currently the practice in most psychology spinal injury centres, to a model where people receive routine psychological health screening and assessment on admission and discharge, with treatment as needed. And this is a model that's been used in Australia for many years, since 2008, and was introduced in the Netherlands in 2018. The other crucial thing was for all patients to be provided with foundation psychosocial skills, a wellbeing group, goal planning to develop self-management skills, peer support, psychosexual counselling, and family and carer support. Next slide, please, Mohit. Thank you. So at the NSIC, we've used a complexity model to guide service provision since 2014, particularly recognising that people who have pre-existing mental health conditions will need more intensive therapy, and our data is that that's about 20% of admissions. And in my experience, mental health complexity has increased substantially in the 29 years I've been at the NSIC. There are about 67% of patients referred are being seen regularly, fortnightly, for mood, anxiety or adjustment work, or receive a time-limited intervention. However, as mentioned, there's a referral model used. So on average, we only see about 71% of the patients who are referred who are admitted. And whereas I don't think we miss people with complex mental health needs, because their needs kind of easily to be recognised, we do miss those who struggle with mild symptoms of depression and anxiety, or struggling to adjust with some aspects of their injury. And from a retrospective audit that we did on 166 patients, we know that 30% of patients had a positive screen on admission for depression, anxiety or adjustment difficulties. And when we screened people again on discharge, 27% of those hadn't been referred and still had difficulties. So you can see the size of the gap. Next slide, please, Mohit. Thank you. So there are psychology gaps in spinal cord injury centres themselves. However, there are even worse gaps for those who aren't admitted to specialist services. And many hospitals in the UK don't have clinical psychologists. Psychological support following discharge is difficult to access, and the NHS offer of talking therapies doesn't currently have a pathway for people with spinal cord injury, unlike other long-term conditions such as stroke, pain, and cardiology. And practitioners are not therefore knowledgeable about the needs of people with spinal cord injury, in particular bladder, bowel and skin management, and the lifelong health regimen associated with that, as well as the specific psychological issues associated with adjustment to injury. So both Backup and the SIA provide services to people across the health continuum, not just those in spinal injury centres. Backup peer mentoring service and the SIA peer counselling are crucial to meet the current service gaps, which is why it was so important that we could partner with them on this project. Next slide, please, Mohit. Thank you. So patients are not discharged from hospital when patients are discharged from hospital when they've reached some physical stabilisation, and they don't need the intensity of inpatient rehabilitation. However, this means that people are often not psychologically ready for discharge, and research has found that psychological stabilisation can take up to 5 years after injury. So multi-nation research involving Professor Paul Kennedy in 2012 found that some people did not have symptoms of depression or anxiety initially, but developed these over time. And these different and changing trajectories has been replicated by research in 2019 from the John Walsh Salter and University of Sydney, involving Professor Rosalie Craig and Professor James Middleton, who's involved with this research as well. And they found that 40% of participants had symptoms of depressed mood at 12 months post-injury, and 27% were at risk of poorer long-term adjustment. And they also found a relationship between high self-efficacy, low secondary health conditions, high positive appraisals, and low negative appraisals. And also, most crucially for us, that the opposite was true, that people with low self-efficacy had high secondary health conditions, high negative appraisals, and low positive appraisals. Thank you, Mohit.
Thank you, Jane. So this particular slide highlights that current peer support landscape for people with spinal cord injury in the UK and Australia. So each organization, which will be the partnering organization for this project, has that distinct but complementary model how they operate. For example, Backup is a pragmatic with strong digital and vocational capability, and Spinal Injuries Association operates as a national coordination and professional counseling services. And SKIA, which is also the equivalent of those two charities in Australia, also deliver an integrated inpatient to community peer support pathways. However, what we learned from some of the insight which we have developed during the development of this project, that there are marked variation in the intensity and excess, with service delivery ranging nearly 5-fold and wait time across the services from immediate to 3 months. But importantly, when we connect all the dots together, all the organizations show that they are ready, and there is a readiness to adopt some shared strategies, creating a clear opportunity for better alignment across the care continuum. Now, I would like to just divert your attention to one of the tools that we have developed in 2023, which was launched by the Ministry of Health in New South Wales, which was developed over 5 years, which we call the Spinal Cord Injury Health Maintenance Tool. This particular tool provides educational information and self-management tips and strategies for people living in the community for common secondary health conditions associated with spinal cord injury, such as pain, bowel and bladder dysfunctions, autonomic dysreflexia, and pressure injuries. The tool can be easily accessible as a PDF booklet, via website, and a smartphone app. And I can provide you the link later on how you can access this tool, and just give you a little bit of glimpse of the tool later in my subsequent slide. So moving forward, why the emotional support, providing that emotional support is so important. So when someone sustains a spinal cord injury, and we have clearly heard from Kat experience. So thank you, Kat, for sharing your story. We heard from her that physical challenges are obvious, but what is often less visible are emotional impacts, such as grief, loss, and a long process of that adjustment. Our team has co-designed this particular health maintenance tool, thinking that those are like some common medical problem. But what we heard during the process of development very clearly that mental health and well-being was the top priority at the time. So in the second phase of the project, in response to that, we developed that dedicated mental health and well-being module. And this particular module focuses on people who may not meet the criteria for that clinical diagnosis, which Jane alluded in her like slides, but also like who still experience that emotional distress, which is just under the threshold of that clinical diagnosis, where their quality of life also affects. And the tool itself builds on that practical coping skills, resilience, and confidence that can be easily by minimum training, like delivered by peer mentors and counselors with lived experience. So why we think like this project matters, because many people do not have access to that specialized like psychological support and services in both countries, as we have also heard from Jane previously, particularly after they leave the hospital. And most of these services, as I previously said, focus on that clinical mental health care. This leaves a significant gap for people experiencing that mild symptoms, but very important because they impact their emotions in longer term. So this mental health module, which definitely helps to address this gap and can be delivered by peer mentor and counselor, providing that early support to prevent more serious mental health problems and reducing that avoidable hospital use. However, even the best resource, that's where the project comes in. Even we know like the best resource will not make a difference until and unless it's properly implemented. That's why this project focuses on three key important implementation steps. First, to understand what are the challenges and opportunity to integrate into like usual practice. Secondly, we can create a practical plan so we can integrate this mental health like module into care. And then thirdly, and finally, putting that plan into action and testing it. In addition, I will also say the impact also goes beyond that. The project will also bring together all the partnering organization together to align care, their model of care, share that learning, develop that consistent evidence-informed recommendation to strengthen that peer-led strategies to transform care and improve quality of life for people, which aligns with the Stoke Mandeville Research Foundation's outcome across the continuum of care across UK, Australia, and beyond. So to finish off today, I would also like to acknowledge the project team who has developed the spinal cord injury health maintenance tool, particularly Professor James Middleton for co-leading the development of this tool, the resource with me, Professor Ashley Craig, who was the lead on the development of mental health module. We also acknowledge our continuous funding received from iCare New South Wales for providing that foundational funding to develop the tool. But in addition, for this current project, Jane and I would like to also acknowledge the support we are receiving from our partnering organization, especially the donors of Stoke Mandeville Spinal Research, their funding support that enable us to undertake this important work. And last but not the least, a special thank and mention of Derek and Charlotte for their encouragement and ongoing support. So thank you.
Thank you very much indeed, Jane and Mohit, for a very interesting and clear presentation of a hugely important piece of work which will impact, I think, on so many people with spinal cord injury, very wide ranging. So I think this is excellent. So I would now like to open up for questions. If anybody has questions for either speaker, please could you raise your hand and we'll take them, or put the question into the chat. So any thoughts from anybody? Perhaps I'll kick off. Sorry?
I have one question. Well, you.
No, Kat, you kick off. Yeah.
About the neuropathic pain medication, has there been like a comparison to how pregabalin or gabapentin and how this new drug has been acts to the pain? I mean, I'm on pregabalin, and I mean, it does something, but it's like not a lot. And is there something like a like to see patients that have taken both medication, what works better for neuropathic pain?
Jan.
That's a good question. Thank you very much. So at the moment, we don't have this head-to-head comparison. And we don't know the effect size of bupropion. We don't know how strong the pain relieving effect will be. But I think in the future,
it's on the going. Good. Thank you.
That study we might question. But one important aspect is also combination therapy. So in many cases, we are combining pregabalin, gabapentin with other kinds of drugs. So that could be potentially interesting in the future. So you might use both drugs at lower doses, so you don't have that many side effects, but you are potentiating the effects. And because pregabalin, gabapentin, and bupropion act on different sides, this might actually be a way of combining them in the future. But this is just wishful thinking.
It just sounds great.
Even
just sounds great to me. Just because it's like, oh, there's something for you. So that's amazing. Thank you. Yeah.
Thank you. Thank you. Any other questions? Yeah, I'm going to ask Jan. It intrigues me, and perhaps this is slightly psychological as well, about the crossover trial. If somebody starts off on bupropion and then goes on to placebo, if the drug has been effective, it may be fairly obvious. But if they start off on placebo and then go on to bupropion, do they then, and bupropion's effective, do they then have such joy at finding relief from the pain that they would over-report the benefit of it? Because by that stage, they will have realized that it started with placebo and went on to the active drug. Do they over-report?
That's a good question. I don't know. I hope this will kind of equal out because it will be hopefully balanced. How many will start on placebo? How many will start on bupropion? But it's not, it's not the ideal design. Maybe it's as good as we can do it, because if we were gonna run a bupropion in parallel, we would need many more patients. So this is kind of a compromise, this study design, that we can reach this and we can get some findings from 35 patients. But I guess what you mentioned could be a potential downside of that design.
Yeah. We've got some questions in the chat. Jamie Rind, you asked, what are the potential side effects of bupropion?
So there are side effects. So common side effects could be, it sometimes affects sleep. That's what we heard from some previous studies. It might lead to some slight forms of insomnia. It can affect the gastrointestinal system, lead to constipation, lead to slight headaches, lead to constipation. But I guess when comparing the side effects to the side effects, if you look at the things from pregabalin, gabapentin, or duloxetine, fairly similar. So nothing really stands out in particular, to my knowledge, for bupropion.
Okay. There's another question from Marina Panagaki. Are there likely to be any trials for this drug in the UK?
maybe in the future, if we have some positive signals from this trial and if we make it public and talk about it, I hope that I follow this, because what I'm talking about is actually using an approved drug and finding a new indication. That's what people call drug repurposing. That's a big thing, I think, in pharmacology, because it's way faster and also cheaper than starting basically from bench and then moving to bedside. So I hope in the future, if we have positive signals from our crossover trial, that maybe other trials will follow in the UK or other countries for that matter.
Yeah. And I suppose related to that is Karen Davey says, how could she get involved? She's a T910 incomplete in the UK. How could she get involved as a participant?
It's also a good question. That is unfortunately a bit difficult because it will be run under Danish regulations. So we cannot, unfortunately, recruit patients from abroad. We would very much like to increase our sample size, to be more inclusive. There are discussions in the spinal cord injury field to do European trials, to be more inclusive of other countries. For this particular trial, with the resources we have available, we are kind of, we need to focus on one country and try to get the best out of it. And then hopefully in the next step, make it a bit more international. Yeah, but that's a very good point. And we hear these questions a lot. Unfortunately, there are regulatory to run this across many countries.
There's a question here from Vida Shika. I think that's how it's pronounced. I apologize if I've got that wrong. I'll read out the question, quite a long one, I think, for the psychologists. Hi there. Thank you for your time and support for SCI patients. It is very much appreciated. I wanted to say that some patients have poor digital technology and English language skills. Some support may be given in rehabilitation hospitals to help patients use services by managing most of the admin. However, after discharge, if they have not been taught these skills, taking care of themselves after discharge can be difficult if they have not learnt these skills and do not have personal carers, or if their loved ones do not have the energy or headspace to help them, sometimes due to their own struggles or exhaustion. Have you considered teaching these skills to patients who do not have these skills before discharge so that they can access mental health support, services, resources well during their stay in hospital and after discharge?
I can perhaps, Jane, from Australian perspective, like maybe from the tool side of it, I can say regarding that poor digital, we call it like illiteracy, digital illiteracy, if they're not like very well with digital tools, technology, or English language skill, I can confirm that's why we have this compendium of the resource, like a paper copy, a PDF version, a website, and a smartphone app where it can cater for different learning styles, what people want, like if they want like a paper version versus a computer version versus a phone version or a website version. Regarding the English language skill, so I can confirm all the modules what we have developed. Currently, there are 6 modules, and I have put the link of the website in the chat. They were written from a level 8 English standards, and they also have a lot of accessibility standards going into it when we were like developing the tool. So that's the first part of your question, and hope I have addressed it, what you were asking. Coming to the second part of your question, where you were like talking more around providing that support before discharge. Yes, in our spinal units in Australia and New South Wales, we do that, and that is pretty much done by our consumer organization as a peer support, mentoring, coaching sessions, where they come and they sit with the person and discuss the tool, some practical tips. but the mental health one is not yet implemented. That what the scope of this project, that we will develop some new like practical strategies and educational material for the peer support. We can say like train the train module, where the trainer can train and then they become the trainer for future. So that's what like the model we were thinking as one avenue, but there will be multiple avenues where healthcare professional can also be like taken that role and delivering that pre-discharge education in their education session. Over to you, Jane, if you want to add from your perspective.
Thank you, Mohit. I mean, similarly, in English spinal cord injury centres, yes, there are kind of assistive support and skills, but I think as the question was saying around, if people aren't in those environments, it can be particularly difficult. So that's why the co-production element of our project is so crucial, because it's the first part around the focus groups and what people need for implementation that we will be scoping. And how they can support, as Mohit said, the backup in SIA to actually implement those skills as part of the kind of that crucial aspect as part of the project. So yeah, that bit's covered off. Thank you.
Thank you very much indeed. And I think it's nearly time to thank people for coming. I'm not going to take any more questions, but I would like just to give an opportunity to Raquel Signamporia, who from Aspire Law, who have so generously sponsored this webinar, if she would like to say a few words. Raquel.
Thank you. And thank you to everybody who joined today. It's lovely to see so many attendees. On behalf of Aspire Law, we're incredibly proud to sponsor this event. So hopefully you've all found it useful. At Aspire Law, we work every day with people with spinal cord injuries. That's all we do. And we see firsthand the life after a spinal cord injury is so much more than just the initial injury, as Kat was explaining in her introduction. It's about the long-term realities. And the reality is neuropathic pain can be relentless and invisible. And that 60% figure, that's a huge amount of people who are affected on a day-to-day basis by it. And it brings, as Kat so eloquently put it, all these emotional challenges that can surface for months, years into rehabilitation. And then you throw in any psychological delays in terms of accessing help, and it just sort of ends up in this really tangled up situation that people are trying to detangle as they find their new way in life, basically. So the research that you've heard about today really does matter, and it matters quite a lot. So thank you, Kat, for setting the scene so eloquently. Dr. Rosner, your research sounds really fascinating. Can't wait for it to get to the UK. And it just shows that innovation in this space is urgently needed. And I often see a lot of chat between gabapentin and pregabalin and all the pros and cons, etc. I hope this offers some, I don't like using the word hope too soon, but some opportunity, some light at the end of the tunnel for people who are trying to work this. And Jane, I love you anyway. I think everything you do is amazing, but it just shows, and maybe I haven't met you before, but I'm sure you're just as amazing. But it just shows how structured, evidence-based approaches to mental health, which has probably been lacking for quite a few years, just shows that should be embedded into rehabilitation. Physical recovery can't be separated from the physical well-being, as we all know, and both deserve equal attention, equal investment, and equal urgency. So as sponsors, we don't see this as a one-off event. We see this as part of the wider commitment to the spinal cord injury community. And we sponsored because we believe our mission aligns with that of Stoke Mandeville Spinal Research to improve life after spinal cord injury in a meaningful, measurable way. So good luck to both of you, or all of you, with your projects. And thank you so much for allowing us to sponsor today.
And thank you once more to everyone who's attended. We've had a great attendance and a lot of interest. And there are some emails from Jane and Mohit and Jan and also ourselves at SMSR in the chat. If you have questions, So if you go to the chat, you can see those emails if you want to make a note of them. If you have further questions that are raised by you during the day, or when you're relaxing in the bath this evening, or whatever it happens, shower, or whatever it happens to be, and you want to get in touch, you can. So thank you very much to everybody, most of course to our speakers. Thank you.